Hello and welcome to Acute Cardiovascular Ultrasound by Dr Richard Beese. My qualifications for this are that I initially trained as a physician and then as a radiologist with a special interest in ultrasound. So everything I talk about today I've seen clinically and also radiologically. So hopefully you're getting a background from two perspectives, a foot in both camps. So let's talk about ultrasound and get some perspective. So this is a map of the world, and it's said that only 20% of the world has access to X-rays or advanced imaging. However, with the advancement of technology, we're now getting portable ultrasound machines that evolved. And sort of 20 years ago, this came onto the market, Sonosite, quite expensive, but it became portable. It came from one of these machines, which were very expensive, about £120,000, down to this, which was about £20,000. But they became portable, and you could take them to the bedside. And with time and Moore's law, which is increasing technology and reducing size, they've come down to the size of iPhones and iPads. And this has come onto the market recently. It's called a butterfly. I've got no conflict of interest at all. But the interesting thing about this imaging system is that it's quite cheap. It's about £1,500. It's within the remit of doctors buying it. And if you think that only 20% of the world has access to X-rays, well, ultrasound could fill that void. And using ultrasound clinically and expanding its use clinically is one of the areas of interest that I have. At the moment, we use it in the radiology department, and we have set pro formas. Has this come up? Sorry, what's happened there? Expanding the role of ultrasound in a clinical setting. I do a lot of ultrasound in ITU, ultrasound in accident emergency in the UK, on the wards. In fact, you can do ultrasound anywhere, out of the hospital, in the ambulance. So I'm going to talk about how we could use it acute cardiovascularly, and in patients who come to A&E, they often come with chest pain, thinking about cardiovascular problems, and it can be musculoskeletal chest pain. It can be ischemic sounding chest pain, thinking it's coming from the heart or ischemic heart disease. Chest pain with respiratory symptoms, thinking more about pulmonary emboli or respiratory problems. And then chest pain radiating to the back rarely, and we're thinking about aortic dissection. So I'm going to talk about ultrasound in the role of these. Now, the ultrasound is an adjunct to the clinical examination with a stethoscope. We can use ultrasound, and point of care echo is something I'm interested in. We can look, and there are three big questions to ask from ultrasound to examine the heart. So if you get the, look for splinter hemorrhages, you get the pulse, is it sinus or is it not sinus? And then examining the heart with a stethoscope and with imaging, you get an awful lot more information. And the three questions that I'm particularly interested in for the heart is, what is the left ventricular function? Is there a pericardial effusion? And is there right heart strain? And you can answer these very simply and quickly with ultrasound. So subcostal view will show you the four chambers, and then if there's fluid around the heart, you'll see that clearly. That's with the adjunct of the chest X-ray. Then the LV function, that's very important, because if you've got a normal LV function, it excludes an awful lot of things like heart failure. There's something called the Simmons test, where you get the left ventricle volume in systole and then left ventricle volume in diastole, and it's diastole minus systole over diastole, I think, is the equation, and you can work out what the LV function is. There's another way of looking for the anterior mitral valve leaflet, And if it touches the septum, then it's normal. And if it's greater than 7 millimeters away from the septum, then you think the heart's enlarged. Another simpler way of doing it is just to measure the heart size and compare it to the thoracic ratio, so the cardiothoracic ratio. And in patients who've got chest pain and respiratory symptoms, one of the key questions is there right heart strain? Is there any evidence of pulmonary emboli? And this is a cross-section of the left ventricle here. It's very muscular and rounded. And this is the right ventricle. And when it becomes dilated, it goes from this half moon to almost a full moon, just here. So we can look for signs. Again, this is all just adding to the clinical picture and giving you information that you don't normally have, information that you can have in the resuscitation room, all very simply by looking at the anatomy and with ultrasound. And again, in the breathless patient, we can use ultrasound to examine the chest as an adjunct to the chest x-ray, such as in this case here. We've got indistinct hemidiaphragms. You can't tell what this is sometimes clinically, but with ultrasound, you'll be able to tell whether it's fluid, whether it's solid. So it could be pleural effusion, or it could be solid, it could be pneumonia, or it could be the fact the patient's supine and you've got some pleural fluid at the back here. But these are indistinct and difficult to tell, and clinically difficult to tell with a stethoscope. Equally, this chest x-ray here, you've got unilateral pleural effusion. You do an ultrasound, you can see that it's an extra pleural effusion with, which is complex and loculated, and you could be thinking about whether this is infection or tumor, most likely to be infection. And again, here you've lost the hemidiaphragm on this chest x-ray, and you've got a meniscus here, an air soft tissue interface, silhouette sign, and it's a pleural effusion. Again, ultrasound is just adding to that clinical picture. Equally, this could be a small effusion and a large mass, and ultrasound will be able to determine that. So ultrasound is very useful in chest pain patients and patients who are breathless. So let's just recap very briefly. So it's the evolution of imaging that has brought ultrasound onto the front line, no longer in departments with these large machines. Doctors and other healthcare, not in the UK particularly, but in other healthcare systems, doctors are starting to use ultrasound as a stethoscope and learning how to do ultrasound at medical school. It just shows the anatomy and the pathology and is able to turn differentials into diagnoses. Very useful. And this doctor here is subcostal view looking at the heart on his iPad. And if he's unsure what he's seeing, he can send this to a senior colleague who can transmit these images and get a second opinion. This patient's a trauma patient and he's looking for a traumatic pericardial effusion. So those are sort of things that we're thinking about, expanding the use of ultrasound into more clinical settings, just to see if it can add things to the anatomy and the pathology and improve our diagnostic accuracy. Very quick, very simple if you know what you're doing, if you know the anatomy and pathology, and if you understand the anatomy and pathology of the acute cardiovascular patient. So let's have a look at some cases and put them into practice. So here's a gentleman who's got chest pain and breathlessness. He's got a tachycardia, he's tachypneic. His chest x-ray looks normal. The silhouette signs are all here of the hemidiaphragms and the heart. We've done an echo and his left ventricle is being compressed and his right ventricle is dilated. And it's got respiratory symptoms. And this is a parasternal short axis view around the fourth intercostal space. And you've got to suspect this patient has got an obstructed right ventricle due to pulmonary emboli. Again, it just helps with the diagnosis, it helps with the differential diagnosis, and then the patient could go on to have a CTPA. There are cases in our hospital where they've seen this on echo and they've actually thrombolyzed the patient because they're so unstable because they've got a dilated right ventricle. It is outflow obstruction. So here again, chest pain, the ischemic sound in chest pain. The chest x-ray is normal. There are things that we can do. I'm doing a lot of work at the moment looking at the intimal thickness of the carotids. This is a carotid ultrasound. And it's said that if the intima is normal, the chances of a patient having heart disease or ischemic heart disease is very low. It's a risk stratification. It's not absolute, but it can be very helpful. At least a third of patients coming into our hospital on the acute medical take have got chest pain of ischemic sounding origin, i.e. possibly coming from the heart or ischemic heart disease. Of those patients, 1/3 of the patients, half of those patients, so that's the 1/3 of the medical take, half of those patients, the heart will be normal. And if we could select out the normals using risk stratification, that would save an awful lot of medical time, and we could concentrate on the patients who have ischemic heart disease. And it's said also that the thicker this intima, the more likely you are to have ischemic heart disease. There's another imaging modality that we don't use in the UK, but they do in other healthcare settings, which is coronary artery calcification. It's basically a plain CT through the heart, and we look for calcification of the coronary arteries. If it's negative, it's got a 98% high negative predictive value. That's huge. So you could exclude patients with heart disease with a simple scan, a plain CT of the heart. We're doing CT KUBs for renal stones. I don't know why we're not doing it for ischemic heart disease, which is a lot more serious. And then if you have coronary artery calcification, you can assess the load of calcification, and you can separate patients into low, medium, and high probability of ischemic heart disease. Very useful, and I'm sure that in time will become on the front line. So it's very, and that would decrease or certainly sort out the chest pains for the acute medical take, and reduce the number of patients that are being admitted, save a lot of money, save a lot of time, save a lot of medical time. But we can do the risk stratifications simply by doing a plain ultrasound of the carotid arteries and looking for intimal thickness. This is an area of interest of mine, and there is good evidence that this is the case. Normal intimal thickness, normal coronary arteries, because atherosclerosis is a systemic disorder. So here's a gentleman who has noticed in the mirror that he had a drooping eyelid and a small pupil, and the medic saw him and he had horners on the left. In the A&E, they did an ultrasound of the carotid, and this is the carotid here, and it's abnormal. That's the jugular vein being compressed, but it's expanded, and there is thrombus in the wall of the carotid. So this is a carotid dissection, and if you remember for your anatomy, the sympathetic supply from T1 is in the carotid sheath, and when it's expanded, it gets stretched, and you get a palsy, and you get horners. So again, ultrasound can be really helpful in trying to make a diagnosis, and that's what medicine is about, is diagnosis, isn't it? Get the diagnosis rather than differential diagnosis, and the patient's benefit. So here we have another patient who's got chest pain that's radiating through to the back. I've done an echo at the root of the aorta. There's this flap, and this is a rule in, not a rule out, but this is aortic dissection. It's a type A because it's involving the root. And again, it's just a simple ultrasound in the presence of this clinical setting can make the diagnosis of what is a life-threatening disorder, type A aortic dissection. The patient going on to have a CT angiogram, but you've made the diagnosis in the bedside. And here's a patient with acute onset on the left side, drooping face, and a hemiparesis, and an ultrasound in A&E showed that there is a proximal right internal carotid artery occlusion with very little flow. Here's the colour flow proximally, here's it distally, and again, this you've made a diagnosis of carotid artery disease and stroke secondary to carotid artery disease, and you can make that at the bedside with these very sophisticated handheld devices. We see this a lot, the acute swollen leg on the right, and here we've done the bedside, an ultrasound, And this is the common femoral vein on the right, and it's full of echogenic material. This is normal vessel. It's echo pore in the center. This has got something in it. And then we compress it, and the vessels do compress around it. They get smaller, but the vein should completely disappear. But it's not compressing at all because it's got echogenic material in, and this is thrombus. This is an acute deep vein thrombosis. And again, done at the bedside, make the diagnosis instantly, refer to the medics, and the patient, using imaging, handheld ultrasound, you get the diagnosis straight away. Equally, you can exclude, if you know how to do a deep vein thrombosis scan of the leg, you can exclude deep vein thrombosis. I had a case late on Monday at 5 o'clock, a lady who they didn't think had a deep vein thrombosis, but had leg symptoms in the calf on the right. The patient came around to the ultrasound department. Within 5 minutes, I've excluded a DVT. There was no muscle tears. And so it's probably a muscle strain that you can't see on ultrasound, but extremely useful for that patient. They've got an answer within minutes of seeing the doctor in A&E. Here's another patient, breathless. Here's the chest X-ray. There's a globular heart. Large heart cardiothoracic ratio is increased. And again, if you've just got the chest X-ray, you're into a differential of what this could be. It looks rather globular. But with ultrasound at the bedside, well, then you can do a subcostal view and you see this large fluid collection around the heart, and this is a pericardial effusion. So instantly making the diagnosis, and also using ultrasound, you can then aspirate it or tap it or drain it, depending if the patient's compromised, if they've got pulsus paradoxus or signs of right heart embarrassment. If you think the right heart is at 5 to 10 millimeters of mercury, the same as the JVP, this is where it gets compressed. You get poor venous return, and then you get all the changes of pulsus paradoxus, etc. Let's just talk about this. A pericardial effusion, it's fluid. It's either a transudate or exudate. If it's a transudate, you think about heart failure, renal failure, liver failure, or some inflammatory changes or inflammation. And if it's an exudate, certainly in the UK, we think about whether it's infection or tumour. The types of infection we think about are TB, and the types of tumour we think about are secondaries. So just from knowing that there's a pericardial effusion allows you to make a diagnosis and also allows you to intervene. And here's another case of a patient with chest pain, examined by the doctor, and there's point tenderness on a rib, thought to be musculoskeletal pain. Done an ultrasound of the rib, and here is the rib cortex. So rib cortex here, and there is a break in the cortex, and there is fluid. This is a subperiosteal hematoma, and this is a rib fracture. Not visible on the chest X-ray. The only way you can see chest or rib fractures on the chest X-ray is if they're displaced. Now you may say, well, why would you want to know if you've got a rib fracture or not? Well, it's an important diagnosis because this is hugely painful and affects respiratory function, and you can get secondary pneumonia from hypoventilation. In fact, rib fractures in ALV have got 10% mortality. So diagnosing is absolutely paramount, because then it allows you to say to the patient how long it's going to take to get better. If the patient is working, you can then let the employee know that there's a rib fracture, and also give them the appropriate analgesia to make sure that they do ventilate properly, and also follow them up. There's a difference between rib bruising and rib fractures, and it's quite marked in their long-term recovery. So ultrasound, absolutely superb, versatile tool that's now become so widespread and at the bedside. It's excellent for demonstrating anatomy and pathology. And it's not to replace clinical, but it just is with clinical and the ultrasound, you can turn differential diagnosis into diagnosis. And I know that being a clinician, when I started using ultrasound, well, my whole practice completely changed. I spend a long time with the patient, lots of paperwork. Now when I do ultrasound, I have several questions. I do the imaging, it takes me 5 minutes, then I generally have a diagnosis at the end of it. And even if I haven't the diagnosis, if it's normal, the patient is wanting it to be normal, it's got a high negative predictive value in certain settings, particularly in the abdomen and pelvis. And certainly ultrasound will be the stethoscope of the future. There'll be clinical stethoscope and then ultrasound, and doctors will be using it. And the versatility of it, they'll be expanding the uses of ultrasound. And if I was a young doctor, I'd certainly try and get my hands on an ultrasound machine and try and do an MSc, because it has huge benefits for the patient and also for the doctor as well, because the doctor he wants to make a diagnosis, he wants to make a firm diagnosis, he doesn't want to guess and say things like, come back if it's not better. You want to know what the answer is, and you can answer it very quickly using ultrasound. And I'm an absolute convert to this imaging modality, particularly so versatile, and have the ability to answer questions very quickly for patients. So thank you for listening. This is my second talk. I have a website, ultrasoundresearchuk.com. It's got large numbers of presentations I've made to the British Medical Society of Ultrasound about the versatility of ultrasound and using it in different clinical settings. And I've written a book, Ultrasound Sans Frontières. Again, it's about developing world ultrasound. It's about using ultrasound in unusual clinical settings, the battlefield, in tents in the desert, in ambulances, the use of ultrasound for the triage of patients, the triage of pregnancies between high-risk pregnancy and low-risk pregnancy. Just the vision and the brilliance of this tool to make diagnosis, and that's what the doctors want. They want to make a diagnosis and to say to the patients. So thank you for listening.